هيبقى كل أربع وخميس وجمعة الأسبوع الجاي إن شاء الله.
Dr. Muhammad, and thanks you because you are giving me this big chance to be with my colleagues and my very eminent orthopedic surgeon in the spinal field. Can I start now? No.
تفضل يا فندم، تفضل يا فندم. هو السكرين اوريدي شات، اتفضل سعادتك.
This talk will be on the biomechanics of the spine. Spinal curve. The spinal column is a load carrier structure that provides wide range of motion and protects the spinal cord with related neurovascular structures. The humans are the only mammals that have a vertebral column with 4 curves in the sagittal plane. And these curves are a particular feature of bipedal locomotion and increase the flexibility and load capacity of the spinal column. As we all know, at birth, the spine of the newborn is C-shaped with 1 curve only. And at about 6 months, when the infant starts to lift her head, the cervical curve developed. Its muscle developed also. Yes? At about 9 months, the infant learned to crawl and stand and start to stand up, and the lumbar curve now is developed, and its muscle developed. Strong back muscle help to give your child the strength and the balance to walk and run. At the end of the first year, there are 4 spinal curves, 2 primary curves, the thoracic curve and sacral curve, and the 2 secondary compensatory curves, the cervical curve and lumbar curve. The cervical curve, which from C1 to C7 is lordotic curvature, has greatest range of motion. So this curve is most vulnerable to injury. The thoracic spine is kyphotic curvature and has greatest protection and the least range of motion. While the lumbar spine has lordotic curvature and balance between protection and segments are the most mobile, therefore degenerative changes are also most common in these segments. Now, what are the forces acting on the spine? These forces include the body weight, tension in the spinal ligaments, tension in the surrounding muscles, and the intra-abdominal pressure. The major form of loading on the spine is axial load, but this load is not pure axial. It is distributed as an axial compression load in one part, and the second part is bending moment of tensile force. Why? This is because the center of gravity of our body weight is not directly upon the vertebral column. It is lie just anterior to the spinal column, anterior to L4, L5, and S1. This creates combined load resulting in axial compression load and anterior bending moment on the vertebral body. This creates stress on the anterior cortex of the vertebral body greater than would be expected from the body weight alone. This anterior bending moment is balanced by the spinal ligament and the muscles. We can describe our spinal column like a crane. It looks like a crane, which is the center of this crane, or the load of the rod of this crane is our spinal column, and the body weight just anterior to it is equal to the center of gravity anterior to this rod, and this load is counteracted by the spinal ligament and the muscle. Now the forces acting on the spine. These forces are increased gradually as we are going down from cervical to thoracic to the lower lumbar vertebrae, which is subjected to the greatest load. In the upright position, upright standing position, the load acting on the intervertebral disc between the 3rd and 4th lumbar vertebra is equal to twice the weight of the body above this level. while during forward flexion, increase the moment arm of the upper body weight and the loads on the functional spinal units. So, we can advise the people who are subjected to sport injury because due to lifting of the heavy weights, to keep this weight as much as possible near to their body during lifting this weight, and bend their knees and keep the back kept erect, so that they, as much as they can, try to reduce this weight and avoid spinal injuries. Forces acting on the spine. The maximum intradiscal pressure occurs during sitting. This is the maximum load on our spine during sitting, and increase more on forward flexion, sitting with forward flexion. Biomechanical study found that this intradiscal pressure in the sitting position were reduced with the use of lumbar support. By the patient with low back pain to wear this lumbar brace to reduce the force acting on the lumbar spine. The minimum load acting on the spinal column occurred during lying flat because no load produced by the body weight. But when you are lying flat during sleep, this load is not zero. There is also load on our spine produced by the tension of the psoas muscle, which originate from the transverse process of the thoracic and lumbar vertebrae. This can be minimized by flexing the hip and the knee to relax the psoas muscle during lying down. And this diagram represents these facts about the load on our spine. The maximum load, as we see, is on the during sitting and bending forwards, which we call the slouched sitting position, and next is the standing while bending forwards and sitting erect, and then standing upright position, and then the minimum load during lying down. The vertebral column is not designed for prolonged period of sitting down. However, this is quite common in modern life and is considerable to contribute to low back pain. The proper position of sitting, a proper sitting position, you should sit with your hips should be flexed and legs should not be extended, and the back should not be overly arched. This is a proper way of sitting if you are going to sit for a long time. And in addition to the axial compression and bending force on our spine, there is torsion and shear load also. Shear load, anteroposterior and mediolateral shearing force, and torsion load due to rotatory movement. Our spine rarely fail in pure shear. Why? Because shear stiffness in horizontal direction needs about 260 Newton to overcome this shear, which is very difficult in our physiological daily activities. Similarly, under normal physiological activities, pure tensile loading doesn't occur. What are the spinal motion segment or the function spinal unit? This is the shortest segment of the spine that has the same biomechanical properties as the whole vertebral column. Each motion segment, as we all know, consists of two adjacent vertebrae that plus intervertebral disc and associated ligaments. Motion in the functional spinal unit occurs at three joints, the two facet joints and the intervertebral joint. Each segment represents three groups of movement: flexion, extension, lateral flexion, bending to right or left, and axial rotation. During flexion, as we all know, there is widening of the intervertebral foramina, about 24%. And there is tensile force placed on the posterior annulus flavum and capsule and posterior longitudinal ligament. The central canal is widened with flexion, and this may be the rationale for some of William flexion exercises, which is advised by the physiotherapist. And this is also can explain why the patient with spinal canal stenosis is usually widen his spinal canal and minimize or reduce the neural compromise. On the opposite, during extension of our spine, the intervertebral foramina narrowed up to 20%, and the central canal is also narrowed. That's why the extension or hyperextension during examination of the patient with lumbar spondylosis or cervical spondylosis, the pain is exaggerated because of narrowing of the spinal canal and the compression on the nerve root. Nucleus pulposus also moves anteriorly. Lateral flexion, the tensile force on the convexity and the compressive force on the concavity. This is the force during lateral flexion to the right or to the left. There is also rotation, and the rotation is characterized by coupling movement, which occurs at the segment of junction, cervicothoracic junction and thoracolumbar junction. There is coupling movement of rotation between these segments. Now, stability of the human spine. What we mean by stability of the spine? Definition: the spinal column ability to react to multiple forces placed on it. This stability depends on active extrinsic factor like the spinal muscles and bony thorax, passive intrinsic factor, which is bone structure, ligaments, and facet joint. The spine itself has minimum intrinsic stability. Our spine stability doesn't depend on the intrinsic factor like the bone structure and ligament and facet joint. The main stability depends on the extrinsic factor. And the biomechanical study shows that only a load of just 2 kilograms applied to the human spine with intact ligament, disc, and facet joint, but devoid of muscles and the bony thorax, cause the column to buckle. Just 2 kilograms can cause collapse to our spinal column without the extrinsic factor causing extrinsic stability. We can classify the type of spinal stability to mechanical stability and neurologic stability. Mechanical stability maintains alignment under physiological load without significant onset of pain or deformity. While the neurological stability, we mean prevent neural signs or symptoms under anticipated loads. The mechanical stability, the classification system depends on the integrity of the spinal column structures in the sagittal plane in thoracolumbar region. According to this classification, we can classify our spinal column into either 2-column theory, which described by Holdsworth in 1960. He classified the columns into anterior column and posterior column. The anterior column complex is formed of the vertebral body, disc, anterior longitudinal ligament, and posterior longitudinal ligament, while the formed of neural arch and posterior ligament complex. The other theory is done by Dennis, 1983. He divided the column into 3-column theory. Middle one is the posterior half of the vertebral body and posterior disc and posterior longitudinal ligament. And anterior column, all the anterior half and anterior half body posterior to posterior longitudinal ligament. What are the key of stability of these theories? Holdsworth considers the posterior ligament complex is the key to stability, which is ligamentum flava, interspinous ligament, supraspinous ligament. And Dennis considers middle column is the key to stability. However, biomechanical study confirmed that the middle column is the primary determinant of spinal stability. But however, isolated NG of this column are rare. Very rare to find just isolated NG to the middle column alone. Usually it is associated with either anterior or posterior column. The compressive, for example, the compressive fracture or wedge fracture affect only the anterior column, whereas the burst fracture of the vertebra involves the anterior and the medial column. That's why the burst fracture is most common unstable fracture, because it affects the 2 columns. while the wedge compression fracture, in most cases, it is stable fractures. Now the distribution of load on both columns. The anterior column is carry about 80% of our body load, while the posterior column is loaded mainly by the tensile forces. It transmits only about 20% of axial load. Both columns resist the shear and the torsion forces. The neurologic stability defined by the neurological finding at the time of presentation and reflects the remaining intrinsic ability of the spinal column to protect the neural elements from further damage under anticipated load. Related to mechanical stability, crucial for intact and incomplete spinal cord injury. Neural intact example in burst fracture with retropulsive fragment. When the retropulsive fragment is less than 45 to 50% of the canal is less than this is canal compromised, and the kyphosis is less than 20 to 30 angles. In these cases, we can say that our neurological stability is stable. This burst fracture is a stable fractures. While if this kyphosis angle is more than 20 or 30 degree and then the canal compromised more than 50% of the canal diameter, this means that this is neurologically unstable fracture and they need surgical intervention. What are the etiology of spinal instability? According to etiology, we can classify them into traumatic and degenerative causes. The react to restore through fibrosis and osteophyte changes, osteophyte formation, to compensate for degenerative instability. And as we mentioned before, diagnosis is depend on the if the canal involved with more than 50% and there is loss of height, this means the kyphotic or corpse angle is more than 30 degrees. This is mean unstable. We can help our diagnosis by direct MR visualization of the disrupted posterior longitudinal complex, and also we can help our diagnosis by CT scan to know how much is the neural canal is, spinal canal is compromised by retropulsive fragment. Spinal instability diagnosis, there is dynamic. When we are going to diagnosis, dynamic deformity worsen, and we can diagnose dynamic instability by dynamic X-rays in different views, flexion and extension. While static shown by X-rays, can we see this by in plane films? There's widening of the spinous process. The distance between the spinous processes are widened. In biplanar deformity, in CT, facet complex disruption, in MRI, there is disruption of the posterior complex ligaments. Now, we are going to talk briefly about the biomechanics of the local anatomy of the spine. The vertebral bodies. Vertebral body is not solid structure. It's filled with bone. It has thin shell of cortical bone surrounding a core of porous cancellous bone. This enables the vertebra to be lightweight and still stiff and strong enough to withstand different types of load. It's formed mainly of cancellous bone, but it's surrounded by thin layer of cortical bone. Under compressive load, the vertebrabicular bone contributes to 25 to 55% of the strength of the dorsolumbar vertebral body. When the patient is less than 40 years of age, 55% of our load is carried by the cancellous part of the bone, because our cancellous bone is still young and there is no signs of osteoporosis. While after 40 years, this share decreases to 35%. And this causes cancellous bone large deformation up to 10% before failure. this difference between cancellous and the cortical bone. While cortical bone is stiff and only small deformation occurred before failure, up to 2% only. The pedicles, they provide the junction between the anterior and posterior column of the spine. They enlarge the lever arm for greatest muscle effectiveness as patella can describe the pedicle as its function is equal as to the patella in the knee joint. It can increase the lever arm and that increase the force of the acting muscle. The spinous and the transverse process, they provide areas for attachment of ligament and the muscles. They act as lever arm also to the ligament and the muscle and therefore reduce the force required from them to maintain function. While the pars interarticularis, this is the weakest part of the neural arch and the weakest part of our spine. During flexion and extension, it is under alternating compressive and tensile loads. The ability to resist these loads forces depend on the thickness of the cortical bone. Once a defect or fracture of the pars interarticularis occurs, these shear forces prevent spontaneous healing. Once fracture occurs, it will not heal at all. This defect without slipping of the vertebra is called spondylolysis. We call it spondylolysis. This defect or fracture of the pars interarticularis without slippage of the vertebra. Because the center of these forces is anterior to L5 and sacrum, body center of the gravity, the vertebral body tended to slip anteriorly. The posterior muscle forces tended to extend the posterior element of vertebral neural arch, thereby tended to open the spondylotic defect and cause spondylolysis. This is if the pars interarticularis fracture or defect is neglected, it will end by spondylolysis, which is a slippage forward of one vertebra over the other. Now the facet joint, they allow motion between adjacent vertebrae. The orientation of the facet joint changes between the different regions of the spine. This gives each region different profile, direction of motion. The facet joint also have load-bearing function with the intervention with the intervertebral disc. They carry up to 30% of the transmitted load, and this varies with the position of the spine. As we mentioned before, with forward flexion, the facet joint can carry more load, more than 30% of our load. Now, what's the biomechanical function of this facet joint? They provide posterior load bear helper, stabilizing the motion segment in flexion and extension. They are involved in the mechanism of rotational kinematic by restricting the axial rotation. They are designed to block forward sliding of the lumbar vertebra. They can prevent the lumbar vertebra to slip forward on the upper one on the lower one. The facet joint capsule limit motions, strongest in the thoracolumbar and cervicothoracic region, where the curvature. Now the intervertebral disc. The intervertebral disc acts as a hydrostatic unit, allowing for uniform distribution of pressure throughout the disc. The intervertebral disc consists and develop internal pressure. This is called the hydrostatic pressure. It is the pressure inside the disc. The pressure exerted in all directions. This pressure can be distributed the load in all directions. The lateral forces again is annulus fibrosus, which is outside layer of the collagen fibers, and superior and inferiorly directed force against temporal end plates, which is cartilaginous structures. Mechanical characters of the disc. It is shock absorber, viscoelastic structure, which provides movement in the functional spinal unit. It has little resistance at low load. It becomes stiffer with increased load. Thus, it provides flexibility at low loads and stability at high loads. It is less stiff in tension than under compression. Compressive stresses on the disc translate into tensile stresses in the annulus fibrosus. This makes the disc stiffer, which added stability and support to the spine. To summarize this means that the disc with load is becomes stiff structures. This gives some stability to the spine and prevent displacement and neurological and any neurological damage. But without load it is hydrostatic structure and less stiff. This diagram shows us the tensile stiffness of the disc annulus in different directions. The highest tensile strength is along the 15 angle of 15 degree, which is parallel to the annulus, the fibrous of the annulus fibrosus, while the lowest is along the disc axis, 90 degree. This is the lowest tensile strength of the disc, because it is perpendicular, this direction is perpendicular to the fibrous of the annulus fibrosus. Mechanical action of disc. Highest along the normal strength direction of annulus fibrous, 30 degree, but it is 3 times stronger than that along the horizontal direction. So in oblique direction, it is 3 times stronger than in horizontal direction. This is the strength of the our disc. Intradiscal pressure is the final determinant factor in disc prolapse lesion, regardless of the load on the spine. Intradiscal load can range from 294 Newton to 333 to 3030 32 Newton, depending upon position, which is very high load. Most load in anterior segments, posterior can load from 0 to 30% depending upon the segment position. And this is experimental study to measure the intradiscal pressures in the lab. What are the creep character of the disc? This character is a special character of our disc. It means that the disc is time-dependent deformation under constant load. Exposed to constant load during the daily activity, it will reduce about 20% daily reversible disc volume. It will lose its 20% of its volume at the end of the day, which is reversible phenomena, and during lying down, it will restore this. This disc deformation is recovered when the applied load is removed, example, sleeping at night. This is called diurnal variation. This diurnal variation leads to changing in person height. So a person is usually slightly taller in the morning compared with the evening. In the evening, we are shorter. In the morning, we are about 15 to 25 millimeter longer when we stand up during in the morning. What are the degenerative disc disease? In degenerative disc disease, there is loss of hydration of nucleus pulposus. About 80 to 90% is lost of the water. This decreases with age. The water content is decreasing with age. Also, by axial compression, creep will occur in the disc, and this will be larger with increased force and aging. Loss of disc height and tears of annulus fibrosus leads to subluxation of the facet joint and increased load on the facet joint, up to 70% of total transmitted load. If we remember, we said that the disc, the facet joint, carry only 30% of our total load. But when the disc is degenerated in degenerative disc disease, the facet joint carry up to 70% of the total transmitted load. These develop degenerative changes which affect load transfer and the movement of the functional spinal unit. And this is a creep character of the aging. They classify them into grades. Grade 0, non-degenerative disc, more viscoelastic, which is normal disc, and grade 2 mild degenerative disc, less substance, and grade 3 severe degeneration disc, more and more deformation occurs. This is grades of degenerative disc disease according to the creep character of the disc. Now the spinal ligament. They are important supporting structure. As we all know that there is anterior longitudinal ligament, posterior longitudinal ligament, ligamentum flavum, interspinous ligament, supraspinous ligament, and intertransverse ligament. They act like rubber band. They have an elastic physical property that allows the ligament to strengthen and resist tensile forces, which allow enough movement without injury to vital structures. Under compression, the ligament buckle and serve little function. The strongest ligament are the anterior longitudinal ligament. The strongest ligament or spinal ligament is the anterior longitudinal ligament, while the weakest ligament is the posterior longitudinal ligament. The inter and supraspinous ligament is of intermediate strength between the anterior and posterior longitudinal ligament. And this is a diagram shows the relative strength of our spinal ligament. And as we show, the strongest longitudinal ligament and the weakest one is the posterior longitudinal ligament. And the interspinous and supraspinous segments are intermediate between these two ligaments. Lastly, the spinal muscle. Spinal muscle have small moment arms with respect to the vertebral joint. The moment arm is the distance from our spinal muscle to the vertebral body is about 6 centimeters. The muscle have, this is called the moment arm of the muscle. The muscles have to generate large forces to counteract the torque produced about the spine by body weight and objects being lifted. To maintain an upright position, this torque is counteracted by the tension in the back extensor muscle. This torque of the extensor back muscle, which is very strong muscle, counteract our body weight in the upright position. Thank you. I hope you get some.
Thank you so much, our beloved professor. Thank you so much, Professor Emad E.Essmat, for this very interesting talk, summarizing all the biomechanical aspects of the spine. Thank you so much, sir.
Thank you. Thank you.
دكتور أشرف إسماعيل معانا؟
معاك دكتور محمد.
دكتور أشرف بيه، ازيك يا فندم؟ منور يا سعادة الباشا.
منور دكتور جلال، منور.
دكتور طلعت. اتفضل يا فندم، سعادتك المودريتور معانا يا استاذنا، اتفضل يا معالي الباشا.
ربنا يخليك. شكرا. بيشرفنا النهارده استاذنا الدكتور طلعت الحديدي. طبعا الدكتور طلعت الحديدي.
الدكتور طلعت جويننج، منور يا فندم.
الله يخليكم يا جماعه.
انا طلعت يعني
شرفت باللقاء معاكم يعني. استاذنا الاستاذ الدكتور جلال كاظم بقالي مده ما شفتوش، ومبسوط ان اشوفه بصحه وخير.
الله يحفظك.
الله يخليك.
دكتور اشرف بيه.
دكتور طلعت.
طب انا اعمل شير ازاي بقى؟
هو هنشوف